Hello, students. We are going to do the OQEs for Chapter 4. So, the first question is, what are some of the ways that we as a society are trying to increase the effectiveness of safe sex practices? A lot of focus seems to be on the youth instead of adults. It is true that efforts are mostly focused on the young. This is because young people tend to have more sex than older folks. However, this dynamic is changing. In more recent years, studies actually show that millennials are having a lot less sex than generations in the past at that same age. So there's some kind of shift in dynamics happening. In addition, the growing rate of single seniors is also causing some, more dating and sexual activity at older ages. And one of the highest growing rates of STDs is in the senior population because when they were young, maybe prior to finding their life partner or whatever, they were not taught as much about safe sex practices and STDs. And so there's kind of some stuff going on there. But it's really an interesting topic that you brought up, and it's definitely worth considering looking into it a little bit further. When counseling a sex offender of the opposite sex, what are the steps that should be taken for the counselor to feel comfortable being in a space with that individual? So, first, I must address the fact that just because an offender is of the opposite sex does not mean that they're attracted to the counselor's gender. And so that's very important to pay attention to, is that the client's gender doesn't always mean their sexual orientation. Some sex offenders may also have a certain type that they offend against. So maybe they've only offended against family members or only children or other vulnerable populations. Excuse me. And really, in most cases, sex offenders are not going to fit the sort of stranger in the bushes paradigm that we think of when we think of sexual offenders. And so most likely, there would be a very low likelihood that they would actually try to offend against their counselor or someone in a position like that, because they don't see them as someone vulnerable that they can groom and things like that. But with all of that aside, there are some things that you can do to have safety measures. And so one is that a lot of clinics and community agencies have like a call button in the office. Maybe it's on the phone or it's something separate that they can press, and it will alert the authorities to come. And so that's definitely a feature that you can have in place. You can also make sure that you don't meet with the client when there's no one else in the building. So make sure it's at a time when there's other clinicians available and someone to kind of hear if there's any kind of yelling or anything like that. It's also important to set up your office, and this is sort of in general, not just with this question, so that you are not furthest away from the door. And so my desk is not in the best position in my office. I'm kind of up against the wall, and the door is in front of me. And so between my desk where I'm sitting and the door is all of our chairs. But when I'm doing sessions, I'm not behind my desk. I'm actually in front of my desk in the chairs closest to the door, and the clients sit on the other side. And so it's really important to kind of position yourself in a way that you can kind of reach the exit before they can. And so that's in general. But in all honesty, the offender is at the point of being in your office, so they're less likely to act out because they want you to give a good report to probation and other authorities so that they don't get into more trouble. And so, again, there's just less likelihood. But they may start to engage in some like psychological manipulation and coercion and kind of push boundaries to see how far they can get. And it's really important to be aware of that, because you don't want them to start pushing your boundaries and you allowing it, because then they're just going to kind of keep going further. And so that's boundaries with anything, with your time, with your space, with your scheduling, with anything. Because having good boundaries and learning those boundaries is one of the things that you need to work out in counseling with them. So this question goes into the STD rates within the country and looking at adolescents and young adults under 25, things like that about condom usage and communication with partners. And so the question is, as mental health professionals, what can we do to educate or advocate for sex education in schools? Or can we even go to schools and provide this information? So this is a tough question because many schools are not going to allow us to come in. It's just kind of going across, red tape and things like that of and the bureaucracy within school districts and stuff. So it can be very hard. It's not to say that you shouldn't offer your services. You can feel free to get in touch with school counselors and administration at different schools and offer your services. That's wonderful. But in addition to that, we can advocate for bills that support education and advocate against bills that do not. And so we can get politically involved. We can go to Days on the Hill. We can write to senators and all of that and talk about the reasons that we feel this is so important, and especially as our role as mental health providers. And that's basically all I wrote about that. Is that don't feel bad if schools and school districts decline your services, but we can certainly offer them. Okay. So this is the second part to that. I believe it's also about cultural religious concerns as well. Many cultures are prohibited talking about sex, and more specifically with females. As a Hispanic Christian female, I vividly remember the preacher at my old church talking about how sex is evil and it does not please God unless it's with your partner with whom you're married. It's for reproduction, not pleasure. My question is, how much of an impact would it make to have sex education offered in churches or allowed by certain cultures? And again, it's something that you can definitely reach out to different churches and stuff, especially if you counsel from a Christian perspective, or like if you want to reach out to like synagogues and you counsel from a Jewish perspective, and so on with other faiths. And so, you can definitely reach out and offer your services. I know that I did a podcast with my church about LGBTQ plus individuals and some concerns where, like it goes against the Bible and Christianity and all of that kind of stuff. And so they allowed me to do that because I was coming from a Christian perspective and kind of opening the conversation. And so reaching out is wonderful. Having the church teach medically accurate sex education would go a long way. So I know that a lot of churches and pastors and things like that, and again, different leaders of different religious organizations will offer like premarital counseling type stuff. Having it discussed at that point would be good, but of course it's at the point where the couple is getting married. But definitely offering it before them would be wonderful, or at least having the conversation open or having people come in. And so I think that the biggest issue is that more conservative churches and stuff like that aren't going to allow that to happen anyway. And so those are the ones that probably need it the most, the children and the young people who attend those churches. And so it can be really difficult, especially because, the push there is to teach abstinence only, which we know doesn't have an effect on, pregnancy and STD rates. Actually probably makes them, I think, a little bit worse because people aren't able to protect themselves when they go out and do it. But the more open we are to talking about it, the healthier and safer choices that we can all make. So it can be helpful. What are the conditions for ethically measured breach of confidentiality if an HIV positive client is intentionally or recklessly exposing a partner or partners? I'm wondering if this is done with or without their notification. Seems like a dicey scenario, and it is. And so I tend to err on the side of caution. And so if a client is, kind of letting me know that they're being reckless with this, I will talk to them about it. I will talk about the impacts of that and the effects of that, and I will try to help them to move forward and try to make those disclosures themselves and be, honest about it. I would also tell them about the laws. And so in Florida, you could actually get federal charges if you knowingly expose someone to HIV and you don't tell them, you don't give them informed consent. And so it is really risky to be doing that and not letting the partners know. So if I were to have to reach out to a partner or let them know, my goal would be to try and help them as much as possible and talk with them. I think that if it were safe to do so with the client, I might tell them, like, listen, if you're not going to disclose this, then I need to. But if I felt like I could be threatened or harmed by the client, then obviously for my safety, I would probably not share it with them. And so you have to kind of consider that based on your relationship with the client. In any case, supervision or consultation would be really helpful and kind of talking it out with somebody about the specifics of the case. Is abortion counseling something that exists solely within mental health facilities? So there's a couple questions about this. And so basically, abortion counseling is something that is required in a number of places in order for people to have an abortion. And the goal of it is really to sort of give information about the other options that a person can make and understand the risk factors and things like that. In practice, it's often a way to talk people out of having an abortion. There are some places that use really manipulative factors, like instead of referring to the person as like a person or a female, they refer to them as mother. Instead of talking about the pregnancy as, a fetus or, whatever level it's at, they will say the baby. They will even gender the baby and things like that to try and get the person to change their mind, which may or may not be in that person's best interest. And so, unfortunately, it can be very manipulative rather than informative and help the person make the decision. And so, it's not typically counselors that do that. It wouldn't be like, a licensed professional in those positions. It's really just a person who works for those agencies that would be giving that information. So they could be like a nurse or something like that. But in many cases, they're just, again, a person who works there who sits down with the individual and talks about those decisions. And so it's kind of a difficult thing because, like, again, there are some laws that require that this happen. And it's really important to let your clients know that if they're going into this process that is something to watch out for, that sometimes those individuals can be really helpful and help them to make the best decision possible. And in other cases, they can be really manipulative. And so kind of watching out for that. How would you suggest going about a patient who's taking antidepressants that's affecting their sexual performance? So this is actually a common occurrence that different psychotropic medications can have an impact on libido, sexual performance, interest in sexual behaviors, orgasming, things like that. And so often this will involve consultation with a medical provider so that, like, whoever's prescribing the medication, so that you guys can talk about it. It also speaks to, like, maybe the medication provider can change the dosage a little bit or offer other medications that can be tried, or like some kind of combination of medications. And there are also other supplements the client can take to help their sex drive or even take instead of the medications. Anyway, so it's something that really should be discussed with their medical provider. In the end, all we can do is help the client to try and sort out their thoughts and feelings to make an informed decision. If they're like, this is impacting my sex life so much that I really feel like I need to be off the medication, then that's something you work on as best you can with the client, or even try to help them, like, while they're on the medication and maybe they're like kind of stabilized, you can help them to build coping skills and stuff in that time while they're doing okay, so that when they start to come off the medication, they can use those coping skills to help them to move forward without it. So it's not too much we can do in that realm. What are some of the coping skills to recommend to a client who are experiencing subfertility? The couple is experiencing hopelessness and stress to maintain their lives without or with their other children who are adolescent age. And so one of the many difficulties couples face when dealing with either infertility or subfertility is that it can take over their life. And so instead of the couple focusing on each other and their relationship or focusing on other children, if they have them, they're focused on what we don't have and how we're going to get it. And so unfortunately, that ends up really hurting the relationship and the person's quality of life, is because that over focus on it. So when the couple lets this take over, they may lose other valuable things such as quality time together, romance, spontaneity, things like that. When the couple has other children, they may be pushed aside or receive less attention or focus due to the couple focusing on conceiving another child. And the other children may begin to feel that they're not enough if they are aware of their parents' sort of maybe desperate attempts to have another child. And so it's really important to be careful with this and help the couple not forget to be mindful of their interactions with their other children and with each other in the relationship. You can recommend taking nights off, discussing conceiving. So, like, go out for a dinner with your partner and don't talk about it. Spend time with your kids and don't think about it. Like, be mindful and focused on, the experiences you're having with them. you can also kind of prescribe these to the client, like use them sort of as homework, it's that kind of CBT-ish. And that can help with those relationships and stuff like that, and potentially help the client to deal with the infertility or self-fertility that they are experiencing. The textbook mentions that there are safe sex practices such as cyber sex. So this is a question about cyber sex. There can be negative effects on individuals. When would a counselor suggest this? So, a counselor may not necessarily directly suggest it. Maybe it's something that the client brings up, and then you have a discussion about it. There are negative effects that it can have, and so it's important to discuss with the client, like why they're looking into cyber sex, how they're going to use it, and how to make sure that they look into cybersecurity and emotional precautions, such as like making sure they're aware of catfishing and how that can have an impact on them, and how they can work to build trust in a cyber relationship. You also want to make sure that they're not getting like so hyper focused in cyber relationships that they're not engaging in sort of like direct social interaction or things like that. So this would typically be something a client would bring up or be talking about anyway, so we wouldn't necessarily bring it up to them. But if you do, it's just, again, something that you discuss with them as a potential option, and discuss the impacts that it could have on them, and then does have on them as they end up engaging in it. So great deal of debate about abortion. As a counselor, what do we do when we get into a situation where a couple disagrees? In the state of Florida, would the decision be only depend on the mother? So just like any other decisions in marriage, the couple has to kind of come together and decide, is this an issue that is worth us like separating over? If we can't come to an agreement about this, does this then have an impact on our relationship to the extent that we can't function? Or is there a way for us to understand some kind of compromise or agreement to make our relationship work, which can be really difficult with something that's this big. The only thing we can really do is facilitate that healthy communication, help the couple to talk about this with each other in civil ways and productive ways, and help them kind of come to a decision on their own. We can offer support, we can offer education, things like that. Abortion laws are changing all of the time within states and regions and the country and whatever. So I would say that it's hard to say, if it's the mother-only decision and things like that, because you'd have to look into it at the time that you're working with these clients and in the location you're working with the clients. So the next question asks about intrauterine insemination, IUI, and in vitro fertilization, IVF. So intrauterine insemination is a fertility treatment that involves placing sperm inside the woman's uterus to facilitate fertilization. The goal is to increase the number of sperm that reach the fallopian tubes and then subsequently increase the chance of fertilization. So it involves a woman when they identify the correct time in her cycle where she would be ovulating, they then insert the sperm. It's kind of like artificial insemination, like when an individual decides that they want to have a baby on their own and they get a sperm donor and things like that. So it's kind of similar to that process, but in this case you might know the sperm donor. Or being married to them or in a relationship with them. In vitro fertilization, however, happens outside of the individual's body. And so it takes the sperm and extracts the egg. Like usually fertility drugs are given to the woman so that she can kind of produce eggs and whatever, and they take the egg out of the body, they take the sperm, they put it together, and then they get the fertilized egg and put that back in the woman. It increases the ability of if fertilization is the issue versus carrying to term, they might do this so that you have that fertilized egg or eggs that are put into the woman so that the fetus can develop and grow into a baby. And so the fertilization is just happening in a different place. So IUI, it's happening inside the individual. IVF, the fertilization is happening outside, and then that fetus is put back inside. And I apologize if I'm not using embryo. It's not a fetus. Embryos are put back in. I apologize if I'm using incorrect terms with those. And so the difference is basically where the fertilization takes place. But also tens of thousands of dollars. And so IVF is a lot more expensive than IUI. It involves typically more expensive hormonal treatments. It involves the extraction of the egg, which costs a lot more, things like that. So definitely a lot more. Usually people will try the IUI first and then move to the IVF if that's not successful. So what's the main difference between abortion counseling and normal counseling? Kind of already went over this. It's sort of like hoops that women might have to go through to obtain an abortion. If counselors have ethical obligations to provide safe sex practice education. So like we talked about this before about like what can a counselor talk about with youth if their parents are not okay with it. And the bottom line is no matter what you're able to talk to the youth about, it has to be accurate and it has to be like ethical information. You know what I mean? You shouldn't be giving them like wrong information just because the parents tell you like this is what we want them to believe. But you shouldn't push it if the parent is saying like, no, that's not something I want you to talk about with the child. If the child keeps bringing it up, you address it with the parent and say, listen, your child keeps bringing up this. Let's facilitate a conversation together, or how do you want to handle this, or whatever. So let me see. So what I wrote down is it's important to have good understanding where the client is coming from and work from there. If a child is unable to this is about birth control and stuff like that with clients for religious reasons. So if a client is unable to take birth control, for example, due to religious reasons, we can always educate them on other birth control methods and make them aware of the high risk of conceiving. So like, the rhythm method and the temperature, the basal temperature charts, and, using fertility calendars and things like that. But if there are beliefs that are harmful or unhealthy, like they're doing things that are actively gonna like harm them because of these beliefs or whatever, then we have to try and educate them as much we can on safer practices. And we can come from a perspective of like, that sounds like that could be really harmful. I think you should talk to your medical doctor about it. Or, I just want you to understand what your options are, things like that. How can you determine if someone has a knowledge of transmitting HIV to another person in a legal case? So again, it would rely on the disclosures from the client. So the client's letting you know that they're actively exposing other people to HIV. And so if you were subpoenaed in court, you would have to state that your knowledge is only based on disclosures from the client. So you couldn't go into court and say like, I know that this client is doing X, Y, and Z. You'd have to say, based on the disclosures that the client has made to me, based on the information they've given to me, this is sort of what I know. How can we as society and counselors offer safe sex education courses beyond school? So you can definitely offer workshops and trainings, and some people may attend, so you can kind of put it out there for free. Local community organizations, through doctors' offices, you can promote it however you want. You can do it for free, you can do it for cost. Go out there and spread the information if you have it. ASECT also certifies sex educators, and so you could get a sex educator certification through them. You can get it through Planned Parenthood. There's lots of different organizations that offer that, and if you have that, then you can go out and feel free to inform people as best or as much as you can. This is again about ethics of breaking confidentiality for STI or HIV exposure. If you have enough knowledge to report, then you may do so. Florida is not a duty to warn state, so the law covers you if you choose to report, but you're not required to do so. In most cases, I try to appeal to the client, encourage them to move forward with the disclosure through support and assistance. Hopefully they are prepared to do so, and I can avoid breaking the confidentiality. What accounts for 25% of incident rates of HIV affecting the young people? I'm not really sure. Some of it may be sex without proper protection because maybe they don't know or don't have access to it. Or they may use some birth controls, like they're on birth control pills, which stop, fertilization from taking place, but maybe they're then not using like condoms and other barriers that could prevent STDs. There's also, I feel like, more of an increase, and this is anecdotal, so this is not based on research. You would have to do that on your own, but an increase in other sexual activities like oral sex and anal sex is being more common. And sometimes people think, oh, well, like, that's not as risky, or, I can't get pregnant from that, so I don't need to use protection. And in those cases, you can still get STDs and STIs and HIV. So also, the money for AIDS education, specifically HIV and AIDS education, has actually decreased since the 80s and 90s because there was kind of like the big epidemic. We just found out about it and all of that stuff. And so there was a lot of money, and that money decreased. And so with the decrease of funding, less and less education and information and protection was put out there. So anyway, this is a good topic to continue to explore. I'm also just aware of the fact that I skipped some of these questions answering them. There's 2, so I will put that in the write-up, but it's not going to be on this video. For abortion counseling, is there a specific counseling course or class that they are required to complete? Not that I'm aware of. I honestly think it could be just sort of anybody who sits down with them, but look into that to make sure, but I don't think that there is any. I've never heard of one. In many settings, counselors may work with adult clients who are contemplating a decision to have an abortion, or on the other hand, adolescent mothers who are considering raising a child. When it comes to our own countertransference and ethics as therapists, how do we manage a pro-life or pro-choice stance when faced with such cases? In other words, can a therapist fully maintain objectivity to support the client? I believe so. I mean, I think that if you are truly aware of your feelings and perspectives behind it, you can seek supervision and consultation and work that out, and just remember to focus on, the client's feelings, the client's beliefs, and, what they feel like is best for them. And we have to go along with that decision, again, as long as it's not something that's so unhealthy for them. So if it really gets to the point where you haven't fully processed it and worked through it yet, you may need to refer the client to someone else. That would be an okay decision to make. I can tell you that personally, I dealt with infertility issues, and during that time I had one client who came in and was trying to make the decision with their partner about having an abortion. That was a really difficult thing to go through because, of course, in my head, I'm thinking about my own desire to have a child, and there they are having, the ability to. But the bottom line is it was what was best for that client and their partner, and they needed to make their own decisions, and I just needed to be supportive and helpful through that process. There was also another case where I had a client come in who had been using substances and then found out they were pregnant and went to rehab and stopped using the substances, which was wonderful. But again, at the same time, I was thinking, I can't have a baby, but they can, and they're not really taking care of their body. And there could have been a lot of that judgment. And so again, I just kind of, processed it out with supervisors and really focused on, the fact that the client was doing the best they could for their child and really trying to move forward. And that's, was my job, was to help them in that. Many clients with disabilities which affect their health might encounter problems associated with sexual functioning or activity. So there are so many different sexual behaviors that a couple can engage in and explore. The possibilities are probably endless. And so sometimes that means shifting the definition of sex. Usually when we think of the word sex, or most people think of the word sex, they think of penis, vagina sex, and that's it. That is what sex is. Or even what sexual intimacy is. They have this clear idea of what that is. But helping yourself and the client could kind of expand your definition and understanding of what that is, and kind of helping them to look into other things. We talked a little bit about this with sex surrogates, so that can be a possibility to help people with disabilities to find out, what they would like to do and what they want to engage in. Let's see what else. Clients can also explore other avenues of their relationship and ways they can be intimate without sex being solely the focus. I've watched a few documentaries and videos, so what I suggest is going down a YouTube rabbit trail when you have some time. There's lots of really good TED Talks and informational videos and stuff like that on this topic, sex and disability. So good to get into. How can we as counselors advocate for sex education, community, and society? We already talked about this a little bit. It's important for us to remember that we're not here to change people's belief systems, unless those belief systems are truly harmful to the client or someone else. But even at that, clients have the autonomy to make their own decisions and have their own paths and own beliefs. So we just do the best we can and not try to force someone to change. The next question asks about basic anatomy and physiology, and how that should be maybe part of our coursework, and in some cases it is. The sexuality and mental health class that I took and that I co-taught actually did have chapters in the textbook about anatomy and functioning and all of that kind of stuff. But one of the reasons that I suggest the recommended book for this course, the What Every Mental Health Professional Needs to Know About Sex by Stephanie Bueller, is because that does have good information in there, and also information that you can directly give to clients. But what I did, if you look at the handout, is I put a bunch of links to YouTube stuff. So what are the parts of the female anatomy? What are the parts of the male anatomy? Jessie talks to her vagina for the first time. Get to know your vulva and vagina anatomy. Reproductive system, male reproductive system. What it's like to be intersex. Sexual and reproductive anatomy. What you need to know about orgasms. The birds and the bees are just the beginning, and the human sexual response cycle. So lots of fun videos for you guys to watch. I think that most of them are relatively short and informative and use like everyday language, and so that's pretty cool. Not only for us to like potentially learn from, but also you can share these links directly with clients who might be in need of some assistance or some education. So good thing to do. The text mentions delivering comprehensive sex education programs to youth. These typically require parent permission. So parental permission is required for counselors in the state of Florida. Most school districts require this as well. This can hinder the number of participants, kind of waiting for that parental consent. Now, there are some places where it's legally okay to give an opt-out consent, which means that like the school will send home a letter saying this is part of the education curriculum for this week or this class or whatever. If you feel you do not want your child to participate, then sign this and turn it in. But only some places are that legal to do. Some places opt-out consent is not a legal form of consent. So something that would be good to look into based on the area you live in. It usually goes by state, but sometimes it's county laws and city laws and stuff like that too. What is the law in the state of Florida about breaking confidentiality to disclose potential harm about HIV? We talked about this before. Remember, it's a third-degree felony, punishable by up to 5 years in prison for someone who knowingly has sex with someone and doesn't tell them. But when we look at mental health laws, Chapter 456 specifically issues an exception for practitioners needing to divulge information related to HIV diagnosis. Practitioners should maintain client confidentiality except in certain circumstances. Practitioners regulated under this chapter, which includes us, are protected from civil and criminal liability in the event a disclosure is made to a sexual partner or a needle sharing partner. So if we do disclose it, we are exempt from any kind of charges coming against us from the client. And so these are the situations. An HIV positive partner discloses the name of their partner or their sex partner or needle sharing partner. You now have information to inform them. The patient has been encouraged to notify the partner. So you're talking to them and you're like, hey, you need to make sure they know, abstain from activities that would be likely to spread the virus. They continue to not listen to that. You can disclose. The practitioner notifies the patient that they are going to notify the partner. The practitioner is acting upon ethical professional guidelines or civil duty, so they're not doing it just to kind of like spread gossip. And notification is completed according to the protocols established by the Florida Department of Health. So you want to make sure that you're following those protocols to do the disclosure. And additionally, practitioners are not liable for failure to disclose. So if you choose not to disclose to the partner, you don't have to. Again, we're not a need to warn state. How would you help a client who has an unintended pregnancy and is struggling between the thoughts of abortion and her religion? This is mostly discussed above. We work within the framework of the client's beliefs and value system. We can make the client aware of options, process their thoughts and feelings, affirm the decision that they end up making, and we can't tell them what to do or give advice. What would you do to counsel an individual whose partner is pregnant but plans an abortion and the client wants to keep the baby? This is tough because the client may not have that many rights. Again, depends on location. If they were able to make the partner keep the pregnancy, would they really want to do that? Because the partner could, end up doing things that would harm the pregnancy or, things like that. And so it's just different discussions you can have with the client to figure it out. The best we can do is process it and help them to deal with any resulting emotional experiences or consequences from it, and make them aware of whatever options they may have and affirm decisions they make. The book suggests that individuals should get tested after unprotected sex. What's the time frame? Okay. Is there a grace period after getting tested? So it varies depending on what the test is looking for. So different STIs have different incubation periods and such. It's good to get tested periodically so that you can catch anything that may have been missed by a previous test. It is recommended to get tested every 3 to 12 months. So depending on how much, how many different partners, or, if you and your partner are not monogamous, you might want to get tested more often. So it just kind of varies, depends. But again, 3 to 12 months is usually the recommendation. Is it more likely that a client comes right out and says that they're tested positive for HIV, or does it take various sessions? Okay, so during intake, I do ask about medical conditions and medications. So this is when this information may typically come out. Sometimes it comes out sooner if the reason they are coming for counseling is related to an STI or HIV. I've personally not had a decision where it came out later, but I understand that clients may not want to disclose it right away. It may kind of come out later, or you're working with a client who ends up at some point getting tested and finds out later. And so that could definitely happen. They could bring that to your attention. As a former educator, I wasn't surprised to learn that current efforts to prevent risky sexual behavior and transmission of STIs are not highly effective. In your experience, what's the most effective way to engage teens in this conversation? Peer educators can be more effective than adults in some cases, so that's an option. Different schools will have peer educators who spread information, stuff like that. I think the most important thing is to make it an expectation or a part of the culture. I spoke with a college student once who said that the RA posted a bulletin board with facts about STIs and sex and things like that, and actually had like a sort of like envelope there that they would refill with condoms, and so people could just like walk by and take condoms as they needed them, and it became just kind of part of, you know, how things are done. You know, it's just we talk about it, we use protection, and that's that. And so definitely helping to make it part of the culture is really important. Obviously that's not always super possible, but try to do the best we can. Also be prepared to listen rather than speak. You know, teenagers and young people don't want to be lectured to. They want somebody to listen to them. And so be open to listening to them and, you know, taking that non-judgmental kind of stance and things like that, and just, you know, kind of be in there. There was something else that went through my head as I was talking about this. The University of Florida, they started this campaign with consent, and they did it in like very like approachable kind of ways. Like they put like these, I don't know how to call them, but they were kind of like comics that they would put up on like buses and billboards and signs and stuff around campus, and it was pretty like, you know, low pressure kind of thing. And I think that seemed like a little bit of a better option. They used different kinds of couple scenarios and stuff like that, you know, made it comfortable for various different individuals and circumstances. So, you know, just try to reach out and find out the best way, maybe by speaking to some other peers, or of those peers who are, you know, concerned about it. What do you think would be best? How do you think we, you know, again, listen to young people. It's very important. What's the most effective way to engage with clients who are hesitant about antidepressants due to sexual side effects? Kind of already discussed this. You know, you talk about the pros and cons, if there are other things you can do about it, things like that. In the end, it's their decision. When having children or adolescents as clients, how do we balance the parents' beliefs? Kind of talked about this already. It's difficult to straddle that line. You have to respect the parents' wishes. You can also help educate the parents on the importance of having that conversation. Give the parents research and whatever information you can. You can also encourage the client to do research of their own. So if they start asking you questions, you can kind of say, here was a place to look, or, you know, maybe you should bring that up to your parents and kind of talk about it. And, you know, or you can say to the parents, hey, your child brought up this is, you know, some information you can use to give to your child, or would it be okay for me to share this with them? Just try to do the best you can. In most cases, research has shown that individuals who choose to get an abortion have made up their minds even before making the phone call. However, they still need to go through the protocol and procedure, the way that the state has mandated it. When providing state-mandated counseling to a client who has decided to undergo an abortion, what is the best way to go through the protocol without breaking the Trust Therapeutic Alliance, since usually the protocol is designed for the client to reconsider the abortion? In my eyes, counselors should take this as an opportunity to cater to their clients based on their needs, but as the counseling prepared may bring harm to the client, being interpreted as judgmental or disrespectful. So the bottom line is if a mental health professional is doing the abortion counseling, it's probably going to be a lot less judgmental and a lot better for the client, because we are going to come from a non-judgmental stance. We're going to be open. We're going to talk to the client about what's in their best interest, let them know all of the options open to them, and just help them make the decision that they want to make and that they need to make for, you know, their well-being. With that said, as I stated earlier, often abortion counseling is not done by mental health professionals. And so that is sort of the situations where people are trying to manipulate or talk people out of having the abortion. So we do the best we can according to our ethical guidelines. Next question is about 1/3 to 1/2 of HIV infections are passed on by people who know that they're positive and are not engaging in safer sex practices. Are most people who fall in these statistics drug users? What could compel someone who knows that they have HIV to engage in unprotected sex and expose someone else? So I'm unsure of the statistics to answer that question. But in some cases, the HIV person may feel afraid of their partner's reaction, and so they go ahead and do it because they're afraid to tell the partner and just kind of like hope that nothing happens. But they may be in denial themselves. Like maybe they fully haven't accepted the fact that they're HIV positive and that maybe their sex life does have to change. Their behaviors moving forward, their lifestyle needs to change, and that's something really hard to grasp for some people and to really accept. And so perhaps they're in denial of it, and so they're continuing to behave in the way they always would have behaved. In addition, kind of talking about the fear of partners' reactions, especially if maybe they cheated and that's how they did it, or they didn't let their partner know that they were a drug user and they get it that way, stuff like that. So there could be so many complicated reasons why people do what they do. Who knows, except the individual. What else? They may not care due to emotional reactions due to their status. Maybe they're like, screw it, I got HIV, I don't care anymore, forget this. So maybe they kind of have that for a while, maybe even a short time. But this would definitely be an interesting topic to explore further. Definitely good research to be done there. Oral sex is safest when a contraceptive method is used. This statement is presented in our chapter. I wonder what the statistics are real. How likely is it that individuals use these contraceptive methods when engaging in oral sex, and is there a difference between gay and heterosexual couples? For instance, some or many men don't like wearing condom during intercourse because they report it diminishes pleasure. So what is the likelihood they would use it when giving or receiving oral sex? Very good points. So this is very dependent. An interesting topic to explore as well. Some people may not use a contraception during, sexual activity because they feel like it decreases pleasure, or it's gross, or they don't believe that oral sex is sex, so they don't use it because of that. But again, this is definitely a good topic to continue to look into and identify some of the reasons why people choose not to use it, even though they know that it could protect them and help them. Another question about HIV laws in Florida, we already answered. I know that men having sex with men are more likely to contract HIV. Is it due to greater amount of men having sex with men participating in and unsafe sexual practices? Maybe unsafe sexual practices? If so, do you think that it's due to the fact that gay couples are more stigmatized than other types of couples? So some of what you stated may be a contributing factor. In addition, some men who identify as gay or men who have sex with men choose to engage in anal sex. Not all, but with anal sex, the risk of transmitting HIV is higher due to potential for tears and blood exchange. And so that's with, male-female sex, penis-anus sex, regardless of, what gender has the anus. And so it's just a more risky behavior, a more risky activity in that case. But historically, I don't know so much about now. When you think about contraceptive usage, it was primarily for preventing pregnancy. I mean, although it protected against STDs and stuff, it was primarily for pregnancy. And so when you think about, especially the AIDS epidemic, a lot of gay men during that time weren't using protection because they're like, we're not going to get pregnant, so we don't need to. And obviously it's become more common, but, there's still definitely people out there who don't use it, obviously. And so it is a big question mark. There's lots of different reasons for this. And again, it is individual to each person and each couple and what they decide to do. I understand that HIV and mental health problems co-occur. Is it that people with HIV are more likely to develop mental health issues? Or is it that people who struggle with mental health issues are more at risk of HIV? And I would say probably both. So individuals who struggle with mental health issues may have symptoms of risky behaviors. So promiscuity, decreased healthy decision making, decreased care or concern for their own or others' well-being, things like that. So they may simply have the issues with their mental health that end up leading to behaviors that could put them at risk. But when you switch it around, there could also be people who really struggle with getting the diagnosis and then end up having depression or anxiety or other concerns. Something else I want to add is for severe mental health issues, especially those not addressed, may lead to like things like homelessness, less social support, and decreased access to resources, which then can potentially put a person at risk as well. Does abortion cause women to have more difficulty getting pregnant when they try to conceive later on? It depends. I'm not sure exactly what all the statistics and stuff are, but there are some studies that show that there is a risk of fertility issues, especially after multiple abortions. But that may not be the case in every individual. It sort of depends on, their fertility to begin with and other factors that may change that. I understand the importance of using a multicultural competency in counseling clients about physical sexual health issues, but I'm not sure about how we can integrate a multicultural competency in counseling about physical sexual health issues. So this could be related to cultural or spiritual beliefs about sex, sexuality, gender, and so on. It could also be related to social cultures and expectations for genders and gender roles. So it's important to have a good idea of what experiences, backgrounds, beliefs, and so on a client has before delving into this topic. So where do those things, their ideas and beliefs and stuff come from? And it could be related to one of their identities or more than one of their identities or intersections of their identities. Our textbook states that abortion counseling for women who have already decided to have an abortion. What if the client comes to therapy to make a decision? In that case, using abortion counseling appropriate or not appropriate? How can we prepare to learn more about the abortion counseling? Is there a training class? So I talked about this a little bit above. In many cases, abortion counseling would still be required. I'm unsure if there are trainings or classes. It would be worth looking into. And in many cases, the abortion counselor does not have special knowledge, certification, or experience. They're just a person that works at the agency that sits down and talks with the person. So, and it's not typically a mental health provider. So that's it for the questions. Like I said, I did skip 2 questions for some reason, and I will type them up so you can look at them. It's question 18 and 20. So if you just want to look at those after you watch the video. That is it. Thank you for your questions for chapter 4.